Greetings, dear learners. In the last class, we were studying ethyl alcohol. Under that, we learned different forms of alcohol, their uses, toxicokinetics, their pharmacological actions, and the features in case of acute poisoning. Continuing with the acute intoxication with alcohol, we will look at the management of the alcohol intoxication. To make the diagnosis of acute alcohol intoxication, combine 1 ml of the unknown solution, add 1 ml acetic acid and 1 drop H2SO4 in the test tube. Heat the gently for 1 minute. A strong fruity odor due to the ethyl acetate indicates the positive result of the ethyl alcohol. This is the bedside test for the alcohol poisoning. Then the blood alcohol level assay, immunoassay or the gas chromatography is the most common method for the estimating blood alcohol concentration in Indian laboratories. Results are often delayed by several hours and may not be suitable for immediate clinical decisions. Serum analysis for the critical parameters like the serum electrolytes, glucose, ethanol level should be determined, as patient may develop hypoglycemia, hypokalemia and metabolic acidosis in form of lactic and ketoacidosis. Additional serum tests for the secondary effects includes the blood urea nitrogen level, creatinine level, liver transaminases and the creatine phosphokinases. It aids in identifying the secondary effects such as hepatotoxicity related to the chronic ethanol use, respiratory depression or the rhabdomyolysis, especially in the presence of seizures. Osmolality and the blood ethanol level is of our prime importance. Serum or the plasma osmolality estimates the blood ethanol levels. A blood ethanol concentration of 150 mg/cent increases osmolality by 21.6 millimoles per kg water. Then the qualitative determination of the urinary ethanol is of our importance. Urinary ethanol is commonly assessed qualitatively in the toxicological screening. Urinary ethanol level may be falsely elevated in the patients with the diabetes. By this way, we make the diagnosis of the patients of the acute alcohol intoxication. Then the treatment of the acute intoxication. Airway protection and the ventilatory support is important. ABCD of life, that is the prime importance as we discussed in the management of the toxicology. Activated charcoal is not useful in case of the alcohol intoxication. Stomach wash is also not of much help. Thiamine 100 mg IV is important to protect the patient from the Wernicke's encephalopathy. Dextrose in the case of adult, that is 25 mg, 50 ml of 50% dextrose solution IV may be repeated as needed. Pediatric patients 0.1 to 1 grams of the dextrose per kg body weight as 25% dextrose solution or 10% dextrose solution is given. It is used to correct the hypoglycemia that is very commonly observed in the alcohol intoxication. Then intravenous fluid shall be administered to overcome the hypovolemia. A variety of drugs has been tried to hasten the elimination of ethanol or reverse its toxicating effects. A variety of drugs has been tried to eliminate the alcohol from the body and to overcome the toxicating effect, including the naloxone, physostigmine, caffeine, but none of them have been proved to be truly very effective in the treatment of the alcohol intoxication. Hemodialysis is one of the best measures. It can eliminate ethanol 3 to 4 times more rapidly than the liver metabolism. May be useful in patients who have taken the excessive amount of the alcohol and they have the impaired hepatic function, and useful in those patients in which the condition deteriorates in spite of the maximal supportive measures taken by the doctors. Then further the symptomatic treatment as required to correct the metabolic acidosis, convulsions, hypotension and other measures shall be taken as required. This is all with respect to the treatment of the acute intoxication with the ethyl alcohol. Then the cause of death in case of the ethyl alcohol poisoning, particularly acute cases, is the respiratory paralysis and the aspiration of the vomit contents. In case of the ethyl alcohol poisoning, it causes depression of the brainstem, resulting in the depression of the respiratory centers, and that causes the respiratory paralysis that results into the asphyxia and the death of the person. Further, aspiration of the vomit content can cause the aspiration pneumonitis, and even the vasovagal spasm that may lead to the death of the person. On postmortem examination, we don't have any specific or the characteristic finding of the alcohol intoxication. However, all the organs will be congested, conjunctiva will be congested, alcoholic smell will be present on opening the body and the stomach, gastrointestinal mucosa may be congested and hemorrhagic, pulmonary edema and the cerebral edema may be seen, blood is the more darker in color and the fluidic tendency. It may be observed at the time of autopsy. Then for the diagnosis of the alcohol intoxication, toxicological analysis is important. So the viscera sample shall be sent for the toxicological analysis. Apart from the routine viscera and the body fluid, one half of the brain or one cerebral hemisphere shall be sent, as well as the samples of the CSF, vitreous humors should be collected and preserved for the chemical analysis. Blood should always be collected from the peripheral veins such as femoral vein and never directly from the heart. Caution must be exercised in interpreting the results of the chemical analysis conducted on the putrefying dead bodies. Since the postmortem production of the ethanol occurs in such cases due to action of certain microorganisms, this can result in the blood alcohol concentration up to 20 to 30 mg per 100 ml even when no alcohol has been consumed at all prior to the death of the person. So, the interpreting the result of the viscera toxicological analysis in case of the alcohol positive result is very important, because the postmortem autolysis and decomposition itself causes increase in the concentration of the alcohol in the body that can give a serious rise in the alcohol content of up to the 20 to 30 mg per 100 ml. So, the reports shall be interpreted very cautiously. Then the various conditions may mimic the acute alcohol intoxication, like in case of head injury, cerebrovascular accidents, intracranial tumor, epileptic patient, Parkinsonism. They may have the certain common features that of the acute alcohol intoxication. So, these things shall be ruled out. Then the psychological disorders like the general paralysis in insane and the hypomania may mimic the alcohol intoxication. Then metabolic disorders like diabetic coma, hypoglycic coma, uremic coma, maybe the comatose condition has to be ruled out, whether this is due to the diabetes, whether this is due to hypoglycemia or whether due to the uremia. Then disseminated sclerosis is another differential diagnosis. Drugs like insulin, atropine, barbiturates, morphine, hallucinogens, antihistaminics toxicity can also mimic the acute alcohol poisoning. High fever, carbon monoxide poisoning are all the differential diagnoses for the acute alcohol intoxication. Then coming to the question that we shared at the start of our lecture. Now, this one particular question we can answer it now. In this case, patient has very large intake of the alcohol. He consumed beer and bottle of the whiskey. Then he consumed most of the bottle of the rum at urging of the upperclassmen. And at the time of the arrival in the hospital, the alcohol concentration shortly after arriving at the hospital was the 510 mg per deciliter. That means it is in the range of the stage of the death actually. So, it has crossed the stage of the coma and it is lying in the stage of death. So, by the blood alcohol concentration, we can very well predict the condition of the patient, and he is almost in the stage of the death. So, the questions were that what was the cause of this patient's death? So, as we already discussed, the cause of death, it could be the respiratory depression or aspiration of the vomit. So, he here aspired the vomit, so aspiration pneumonitis could have developed. That is also one reason. Apart from the respiratory depression, both of them could have resulted in his death. And then if he had received the medical care sooner, what treatment might have prevented his death? So, we already discussed in the treatment that there is no very specific treatment, but in case of very high intake of the alcohol, hemodialysis may of importance and it may help to recover in faster. So in this case, hemodialysis may be of the appropriate use. This is all related to the acute intoxication of the alcohol. Then coming to the chronic alcohol intoxication, that is also known as alcoholism. So alcoholism is a chronic disorder characterized by a pathological craving for the alcohol, recurrent blackouts or the memory lapses during the episodes of intoxication, manifestations of the withdrawal symptoms upon cessation of the alcohol consumption. These all features characterize the chronic alcohol intake or the disorder where the patient is unable to control his desire and he is addicted to the alcohol intoxication. And now, if he doesn't take the alcohol, he may have the certain unbearable signs and symptoms that compel him to take the alcohol. So, this is the basically the addiction of the alcohol. So, to assess the alcoholism, patients should provide a detailed account of their typical weekly alcohol consumption. Alcohol consumption is measured in the standard units, with each unit containing approximately 8 to 10 grams of the alcohol. We already talked that a standard drink is the 10 grams of the alcohol, that is the 30 ml of around the any whiskey or the those who share containing more than the 33% of the alcohol will have the 30 ml is the one pack. Problematic drinking pattern shall be identified when the alcohol intake exceeds the 20 units per week for men and 14 units per week for the woman. So it is indicative that if a male is taking more than 3 packs a day, in that case it is alarming sign that we should be alert about the alcoholic intoxication. Laboratory test for the alcohol abuse is the mean corpuscular volume and the gamma glutamyl transpeptidase. They are elevated in the individual with the chronic alcoholic abuse. Gamma glutamyl transpeptidase are the metabolites of the alcohol. They are seen in the chronic alcoholic intoxications. Then the alcoholism is associated with the certain genetic basis. It has been observed that about 45 to 75% of liability for the chronic alcoholism is due to the genetic factors. Alcohol dehydrogenase 1B and alcohol dehydrogenase 2 are the strongest known effects on the risk of alcoholism. The genes including the GABA receptor A2, CHRM2, KCNJ6 and OST-S2 are also associated with the risk for the alcoholism. Individual carrying even a single copy of the ALDH2 504K display the Asian flushing reaction when they consume even a small amount of alcohol. This includes the prominent facial flushing, tachycardia and nausea. So in those patients, they will avoid to take the alcohol. So there is both the genetic basis for the intake of the alcohol and the genetic basis for the not intake of the alcohol, because they will have the certain specific unwanted reactions that they will avoid to take the alcohol. In this way, alcoholism has a genetic basis. Then the medical complications with the chronic alcohol abuse are seen on all the systems of the body. On the gastrointestinal system, it causes gastritis, periodic diarrhea and an increased risk for the upper gastrointestinal cancer. Liver manifestations include the fatty liver with portal hypertension, hepatitis and the cirrhosis. Pancreas, chronic alcohol abuse can lead to the acute or the chronic pancreatitis and an increased risk for the pancreatic cancer. On cardiovascular system, alcoholism is associated with cardiomyopathy, dysrhythmia and the hypertension. On central nervous system, neurological complications include the polyneuropathy, cerebellar degeneration and increased risk for a stroke. On respiratory system, it can cause the aspiration pneumonia and alcohol-induced asthma. As it is very well known that alcohol causes the damage to the liver. So, the normal liver on exposure to the alcohol causes changes into the steatosis, that is the fatty change, and then this cirrhosis is developed on the continuous exposure. Here you can see in the picture that normal liver to steatosis is a reversible phenomenon, whereas when continuous exposure cirrhosis develops, it is the irreversible phenomenon, that is the fibrosis of the liver has developed. As well as for the hepatitis, it is the reversible phenomenon, whereas if the hepatitis has converted into the cirrhosis, it is irreversible. And once the person has abstinence, then it may return to the normal liver in case of steatosis and the hepatitis, but not in case of the cirrhosis. So it has been observed that excessive ethanol consumption causes more than 60% of chronic liver diseases and accounts for 40% to the 50% death due to the cirrhosis. Between 90% and 100% of heavy drinkers develop the fatty liver, that is hepatic steatosis, and those 10% to 35% develop the alcoholic hepatitis, whereas only 8 to 20% of the chronic alcoholics develop cirrhosis. This picture is depicting the histopathological picture of the fatty liver disease. Here, a mix of the small and large fat droplets are seen as a clear vacuoles that is most prominent around the central vein and extend outward to the portal tracts. Some fibrosis can be seen a stand in the blue color. This stand is the Mason trichome stand. This is the characteristic perisinusoidal chicken wire fans appearance in case of the steatosis. Then on the heart, it causes the dilated cardiomyopathy. Here the 4-chamber dilatation and hypertrophy are evident. A small mural thrombi can be seen at the apex of the left ventricle. On the microscopy, we can see the hypertrophy of the myocytes and the interstitial fibrosis that has been stained with the blue color with the Mason trichome stand. And then on the pancreas, it causes acute pancreatitis, that hair hemorrhage can be seen in the pancreas. This picture of the acute pancreatitis, the microscopic field is showing the region of the fat necrosis on the right side and the focal parenchymal necrosis at the center. And this is the histopathological picture of the chronic pancreatitis. The chronic pancreatitis is characterized by long-standing inflammation that leads to the irreversible destruction of the exocrine pancreas, followed by eventually the loss of the islate of Langerhans. The most common cause of the chronic pancreatitis is the long-term alcohol abuse. This right side picture shows the extensive fibrosis and atrophy and have left only the residual isolates on the left side and ducts on the right, with the sprinkling of the chronic inflammatory cells and the acinar tissues. In this way, even at the autopsy, these findings help to diagnose the chronic alcoholic intoxication. Then apart from that, various other organs that are involved are the endocrine system. There, the chronic alcoholism may result in the hypogonadism and feminization in males, as well as menstrual irregularities and the infertility in the females. Blood, the picture of anemia and thrombocytopenia are common hematological complications. A skeletal muscle, it causes the myopathy. On the nervous system, it has an important effect that symptoms such as Wernicke's encephalopathy, Korsakoff psychosis, dementia and the alcoholic hallucinations may occur as a neuropsychiatric manifestations. It also has the teratogenic potential, particularly in case of the fetus. Fetal alcohol syndrome, that is characterized by the facial dysmorphias, developmental delay and the neurodevelopmental abnormalities in the children born to the mothers who consumed alcohol during pregnancy. It can also be the carcinogenic, as it is associated with the increased risk of the cancers in the liver, esophageal, breast, prostate and the colorectal cancers. Then the fetal alcohol syndrome, that is produced as a teratogenicity of the alcohol intoxication. It is seen in the case of the maternal alcohol abuse during the pregnancy. If the mother consumes the alcohol during the pregnancy, then the fetus may present with the various abnormalities like a small head, low nasal breathe, small eye opening, short nose, thin upper lip, underdeveloped jaws, smooth philtrum, flat mid face, epicanthal folds. Apart from that, the neurological development is not proper, so it encompasses prenatal and postnatal growth disturbances along with the mid-face abnormalities. Neurological implications includes the learning and attention deficit, that is prevalent neurological issues associated with the fetal alcohol syndrome. Brain dysfunction is a primary concern with the syndrome, often leading to the cognitive impairment. Pathogenesis with respect to the fetal alcohol syndrome, it is seen that it causes the neuronal death, that is the central to the pathogenesis. Alcohol exposure during the fetal development can lead to neuronal apoptosis, contributing to the neurological deficit seen in the affected individuals. Fetal alcohol spectrum disorder is an umbrella term encompassing all the adverse effects of alcohol on the fetal development. In this way, the fetal alcohol syndrome is the important in case of the alcoholism. In this way, fetal alcohol syndrome is of our importance in case of the alcoholism. Then, after the chronic alcohol abuse, certain withdrawal syndromes that we need to know that is important associated with the chronic alcoholics. Abrupt cessation of the alcohol intake can precipitate various withdrawal syndromes like common abstinence syndrome, alcoholic hallucinosis, seizures, alcoholic ketoacidosis, delirium tremens, Wernicke-Korsakoff syndrome. These all syndromes we will be discussing one by one. In case of alcohol withdrawal, common abstinence syndrome that is typically begins 6 to 8 hours after the cessation of alcohol consumption. Features in this case are the tremors affecting the hands, legs, trunks, often referred to as the shakes. Agitation, restlessness and anxiety in the patient is there. Sweating, nausea, headache and the insomnia is present. Alcoholic hallucinosis is another withdrawal syndrome. Here it occurs 24 to 36 hours after the last drink. The features are distorted perception of the objects, shapes and the sizes, visual hallucinations such as seeing moving shadows, auditory hallucinations including hearing voices and snippets of the music. These all can be seen in the alcoholic hallucinosis. Then the treatment for the alcoholic hallucinosis is the phenothiazine such as chlorpromazine that may help to manage the symptoms. Then the seizure syndrome, that is the Ram's fit. It begins at around 7 to 48 hours after the alcohol cessation. Here the patient presents with the clonic-tonic seizures, commonly referred to as convulsions or the seizures. Here the patient presents with the clonic-tonic movements or the seizures. Loss of consciousness may also occur. And the treatment for this seizures is the benzodiazepines like diazepam, lorazepam are typically administered to control the seizures. Then the alcoholic ketoacidosis is another withdrawal syndrome that occurs 20 to 74 hours after the cessation of the alcohol consumption. Features of the alcoholic ketoacidosis are drowsiness, confusion, tachycardia and tachypnea. It may progress to the Kussmaul's breathing pattern and the coma may occur. Treatment of the alcoholic ketoacidosis are the correction of the volume depletion and the electrolyte imbalances. Potassium supplementation may be necessary and the thiamine administration is essential to prevent from development of the Wernicke's encephalopathy. Then the remaining two important alcohol withdrawal syndromes, that is the delirium tremens and the Wernicke-Korsakoff psychosis. Here in the delirium tremens that occurs around 3 to 5 days after the last drinks, characterized by the sudden onset of the disordered mental activity, clouding of the consciousness, severe agitation and the restlessness. There is vivid visual hallucination, tremors and the ataxia. Autonomic disturbances such as sweating, fever, tachycardia, hypertension and dilated pupils are the seen. Treatment for such patient is ensuring well light and the reassuring environment. Administration of benzodiazepines like diazepam to control the agitation. Thiamine supplementation and the correction of the fluid and electrolyte imbalance is the crucial step. In this way, patients of the delirium tremens presents. I would like to share the case that we started with. In that case, now you can make the diagnosis. Here the person, that is young married person working in the factory, he ran out of the money and the liquor for about 3 days. So the symptoms that he is presenting is after the 3 days of the alcohol withdrawal. The symptoms are the vomiting, tremors of the hands and the tongues, sweating, wild eye, that is dilated pupils, confused, and the insects are crawling on his body, that is the auditory visual hallucinations, that is the tactile hallucination he is having. He has the raised blood pressure, respiratory rate and the temperature is increased. All these the features, and there is the grand mal seizure, all the features of the delirium tremens. So the diagnosis is the delirium tremens. You can very well now recognize that this is a case of the delirium tremens, that is sudden onset of disordered mental activity, confusion, clouding of the consciousness, severe agitation, restlessness, vivid visual hallucination, tremors, ataxia, autonomic disturbances, sweating, fever, tachycardia, hypertension, dilated pupil. All the symptoms were present in this patient. So the diagnosis of this patient is the delirium tremens. Then coming to the another alcohol withdrawal syndrome, that is the Wernicke-Korsakoff syndrome. Here this syndrome comprises of the two phases. One is the Wernicke's encephalopathy and the another is the Korsakoff psychosis. During the Wernicke's encephalopathy, this is the acute phase and the patient presents with the confusion, ataxia, ophthalmoplegia and the altered mental status. This can be remembered as GOA, that is global confusion, O for ophthalmoplegia and A for the ataxia. It requires the immediate treatment with the high dose of the thiamine, because this is due to the deficiency of the vitamin B1, that is the thiamine, that occurs along with the alcohol consumption. Then another manifestation is the Korsakoff psychosis. This is the chronic phase marked by the severe memory impairment and confabulation. Treatment involves the long-term thiamine supplementation and the supportive cares. So, understanding and managing these withdrawal symptoms is the critical in the treatment of individuals suffering from the chronic alcoholism. Early recognition and the appropriate intervention can prevent severe complication and improve the patient outcome. In this way, the withdrawal symptoms of the alcohol intoxication are very important for our understanding on the alcoholic poisoning. Then the case that we discussed at the start, now you can make the diagnosis. Here the 30-year-old male with a fever was admitted with the altered mental status. For 2 days, the patient had a medical history of hypertension and was compliant with his medication. So this hypertension is separate, his medical history apart from this alcohol. As per the patient's family, the patient drinks alcohol socially since more than 10 years and has not had any episodes of the confusion before. So now he is presented with the confusion. The family denied any history of the chills or fever at home. His initial vitals at emergency department is respiratory rate 14, blood pressure 130/80, that is within normal range, temperature is 101.5, that is hypothermia, heart rate is 137, and the patient was acutely agitated in the emergency department, agitation, and the physical examination showed that the patient was alert but not oriented to the person, place or the time. Neurological examination showed no motor and sensory deficit. The patient had the gaze palsy with the direction changing nystagmus. Pupil examination were unremarkable. Examination of other systems revealed no abnormalities. And on MRI, we can see the hyperintensities on the medial thalamus region, inferior colliculus and the periaqueductal region. So all these, the features of the thiamine deficiency on the MRI, you can see here the GOA mnemonic that I told you, global confusion, ataxia and the ophthalmoplegia is seen in this patient. So this is the diagnosis of the Wernicke's encephalopathy. You can very well make the diagnosis in this way. This is all for today. Thank you.